Yeah, good afternoon, everyone. So today I'll be presenting our study on accuracy of a modified diagnostic algorithm for red eyes. So as we know, red eye is probably one of the commonest symptoms that we see our patients come to us with, and there are a myriad of causes that could cause this red eye. Now, differentiating between these causes is very important because most of our red eye patients would still be treated and handled by the primary care physicians. And why is it important for them to differentiate? Because you know which are the serious ones that need to be referred and which are the ones that you can treat in the primary center. Now, algorithms are usually designed to help novice doctors or training doctors to diagnose accurately. Now, one such algorithm is the Edinburgh red eye algorithm. It's a validated algorithm, and it helps assist non-ophthalmic practitioners in the UK. We modified this algorithm, made it a little simpler for our Indian subcontinent, and our aim for this study was to evaluate this diagnostic accuracy of this modified red eye algorithm, and this we applied to digitally acquired images. Now, it was a prospective observational study, and we had 5 study participants. So we tested this algorithm on 5 participants. And how was it tested? Using a digital repository of smartphone images of 115 patients with recent onset red eye. Now, recent onset meaning within 4 weeks. This was our exclusion criteria. Now, 2 ophthalmologists were considered the experts. We screened the OPD, got the 115 red eye consenting patients, captured their red eye images using a smartphone, and uploaded it with a brief metadata into the digital repository. Now, we use this repository now on these 5 participants. Who were the 5 participants? We had 3 primary care physicians, 1 medical student, and 1 intern. 1 internist, internal medicine specialist. And we checked their diagnosis with this digital repository and compared it with the diagnosis of the expert. Now, for the purpose of analysis, we split the group of the 115 patients into 2 groups, Group 1 and Group 2. The Group 1, more serious cases requiring an immediate referral. The Group 2, innocuous conditions. Now, for the agreement analysis was calculated using Cohen's kappa, and we had a sensitivity and specificity of the algorithm to differentiate between the groups, also calculated. Now, this was the modified algorithm that we have used, and these were all the diagnoses that were included. Now, this is just to show you what our digital repository looked like. This was the image with the brief metadata, and this was how we expected the algorithm to be used to arrive at the diagnosis. Again, images showing you how we could have used it. Now, we had 115 patients, out of which in Group 1, which was the serious causes like ACG, keratitis, and iritis included in that. And we had the Group 2 of the innocuous, which was all the other diagnoses. Now, our sensitivity and specificity to differentiate between these 2 groups was 89.2%, and the specificity was 95.1%. This was our distribution of cases. As you can see, the Group 1, we had keratitis, as most number of cases we had was keratitis, and the most common case in the Group 2 was conjunctivitis allergic. Now, our agreement analysis was quite high, especially with the medical student, followed by the internist. This was our Cohen's kappa. It was 0.829 in the medical student, and it was 0.787 in the internist. This was our individual diagnostic accuracy for each of the diagnoses. In Group 1, the highest accuracy was for ACG, but we had just 2 patients. And in Group 2, it was conjunctivitis at 90%. Now, the agreement between our participants and our experts was very high, and it was statistically significant. And the agreement was, as you'd seen, was the highest in the medical student, followed by the internist. Now, the study was actually diagnosed to test this accuracy and the algorithm's ability to make a diagnosis when you're using only images and clinical data. There was a study previously done by Timlin et al. Who used the algorithm, but they had the patients to validate this on, and yet our diagnostic accuracy was similar to theirs. The distribution of cases was similar to other studies, and we had a higher diagnostic accuracy for the innocuous versus the serious, again, similar to the other study by Timlin et al. Our limitation is we had a lower incidence of serious cases. This could be because of natural selection. And the metadata may not have been lucid enough for the primary care physicians. We conclude that this algorithm is clinically useful because of its high diagnostic accuracy and its ability to discriminate between the groups. And this would really aid the primary care physicians in differentiating the red eye causes, because they will know which are the serious cases that need to be referred. And our modified algorithm would serve as our first step in probably developing an AI tool. Thank you. 95, yes. No, this was to differentiate between the two groups.
For these red eye cases, we would love like not to miss those cases which
Yes.
actually have to be there, right?
Yes.
So anything about the like specificity for like for glaucoma you mentioned was 100%.
Our diagnostic accuracy was 100%. So that means, yeah, the two cases were, yes, yes.